Without further ado, we'll kind of just jump into lumbar back pain. We all experience lumbar back pain. As a matter of fact, 65 to 80% of people will have lumbar back pain at some time in their life. Not exclusive to, but certainly most prevalent in less than 45 years of age. Patients is one of the leading causes of chronic pain syndrome and limitation of activity. It's the third most common cause or need for surgical indication in the United States, and it most commonly affects women. So what's the natural history of lumbar back pain? Well, the natural history is actually pretty good. People with lumbar back pain, for the most part, get better within 1 month. Greater than 90% are better than 8 weeks, but there is that group of people, 7 to 10%, develop chronic lumbar back pain, and it accounts for an awful lot of dysfunction and pain and an awful lot of doctor visits, accumulating to greater than $100 billion a year spent in the United States on trying to manage lumbar back pain. And this is why everybody's here, to figure out what we can do to make things better. During the course of the time, we've also tried to figure out what we can do to help people with chronic back pain, whether it's a spinal injection, whether it's a surgical procedure, or whether it's these costly things. And you can see this is what's driving this price up. It comes down to what's going to be the best option for you as the patient. It's going to be a collaboration with you and multiple doctors. Generally, we require or request a multi-specialty therapy process for chronic lumbar back pain, including an orthopedist, rheumatologist, primary care doctor, possibly some combination of that, physical therapist, and maybe a spine or pain management doctor can be involved as well. So when you talk about spinal and lumbar back pain, we ask ourselves, what are the structure of the lumbar spine, to give us an idea about when we get into specific causes or potential causes of lumbar back pain. We need to know what we're talking about with the anatomy. So the cervical lumbar vertebrae, we have 7 of them at the top of our neck. Middle thoracic vertebrae, we have 12, and then 5 lumbar vertebrae at the bottom. And when we talk about lumbar back pain, a lot of the symptoms I described can be translated to, or you can kind of think about it in those same other areas, because the symptoms can be very similar and progress and evolve just like the lumbar spine can. So you think about further, okay, how do these little back processes stack and what they look like? You have the vertebral body, and then you have this little pedicle that comes out in this vertebral process, the spinous process on the back. The bones stack one on top of the other, and there's a joint between the vertebral body separated by a disc, and another joint back here, the facet joint. So any process that affects, like degenerative process that would affect the joint here or here, could potentially encroach on this area where a nerve comes out, or possibly right here where the spinal cord sits itself. Can also cause pain. When you also think about how the spine is aligned, you have muscles which are not shown here, but they can be involved sometimes, as well as the anterior and posterior longitudinal ligaments. Any process that can affect this or cause an abnormality in stability or function can potentially cause pain, and we'll go into those right now. So you think about what's the process that's going to cause pain. There's structural mechanical problems, and that's what the focus and meat of this lecture is going to be on. 95% of the time, pain from the spine comes from some type of process that's altered the anatomy or mechanics of the spine. 1% is going to be a combination of an inflammatory process, and we've all seen patients when or people that you call their name, rather than them turn their head to the side, they kind of got to keep their neck straight. That is a feature, not exclusively to, but it can be an inflammatory back pain called ankylosing spondylitis, and it presents and manifests a little bit differently, and we'll talk about how to differentiate the two. Metabolic processes of the bone, we talk about the bone is formed, and you can have overproduction or underproduction or a balance. Any overproduction we consider like something like Paget's disease can cause pain. Underproduction, osteomalacia in itself can cause pain, or possibly something with osteoporosis and a fracture can cause pain as well. A neoplastic process, something to the effect of metastatic cancer or primary cancer to the spine, is something to consider, and we'll kind of talk about things to give you an idea about, think about that as an issue. But nonetheless, these features are far inferior in being presenting than you see with structural mechanical, but nonetheless, they're things that you have to consider and as a possibility in what's going on. Abdominal or internal organ disease, something like an aortic aneurysm, cyst on the kidney, but infection of the kidney or something in the intestines can also cause pain in your lumbar spine. It's something to consider as a possibility. So the natural history of pain and what to talk about, and where it gives an idea about if it's a mechanical pain, inflammatory pain, and what to do about it. This is what, as physicians, we think about. It kind of goes through our mind. So mechanical back pain is something that's caused by, as we mentioned, something in that anatomical structure. It tends to increase with activity. So you wake up in the morning and you're like, hey, today could be a good day. Maybe it's going to be all right. And as the day progresses, you start to have more symptoms and more complaints. By the end of the day, you're a lot worse than you were at the beginning of the day. This is an indication of something with mechanical back pain. By laying down or relieving pressure off your back or weight-bearing load on your back, it tends to get better, which is in contrast to something like an inflammatory back pain, which happens much earlier in age. And people complain of morning stiffness. When I wake up in the morning, my back is just really stiff, and I got to get up and I exercise, and it makes me feel better. And towards the end of the day, it's actually better than it was at the beginning of the day. This is an inflammatory type back pain, generally how things present. It could also, whenever you're inactive, it becomes more of a problem. So the second half of the night, you start to have problems. When you start thinking about like a malignant process or something, an infection, this is generally, if you're going to give something to think about or give you a clue that that's what's happening, people say that when I lay down and I'm trying to get comfortable and rest, that's all I can think about is this nagging, gnawing pain in my back or in a particular region. That's just when you start thinking about something that's an expansive process inside the bone that's causing a discomfort. And it gives you an idea about where to go. Granted, it's not 100% certainty, but it's something to give you an idea about where to go. Do we have mechanical back pain, inflammatory back pain, or something other process that's going on? And that's going to guide how we work you up and how we direct your therapy as a physician. So, patient percent of this, or perspective, pain. How does the pain describe? Is the pain localized to one area of the back, or does it radiate down into the legs? When pain radiates down into the lower extremities, most people would come to the conclusion it's sciatica. Well, it doesn't have to be. It can be other things as well. And I'm going to describe exactly what that is and how to know the difference. Sometimes when people have heart attacks, they'll describe pain that radiates up into their jaw or into their arm. The pain is not in their arm or in their jaw. The problem is in the heart. But nonetheless, you have what's called referred pain. And this is where we have sclerotomal pain. A lot of times we can have back abnormalities, mechanical changes in the spine that causes what's called sclerotomal pain that tends to radiate into the buttock region and into the legs, but generally stops at the knees. It doesn't go below the knees. Anything that radiates or goes below the knees is more consistent with a nerve pinch or nerve problem. And we'll go further into that. Any numbness or weakness, is going to think more directed towards some type of nerve involvement, a pinch on the nerve, a pinch on the cord, and it's going to give us something to give an idea about where we're going to go, how we're going to work this up. So, when you talk about pinched nerves and pain radiating, well, how can you look at a patient's symptoms and describe where the exact process is? And this kind of map helps us out because we know that as the spinal cord comes down our spine, it generally stops right here at L1, L2. Everything below this happens to be just nerve rootlets coming out, these little roots that kind of come off, and this allows us, whenever you need to have a spinal block, you can take a needle, insert it right into the spine, and you're not worried about pinching the cord if you went up higher. So that's going to allow us to have a lot more mobility, a lot more bulge, a lot more activity in this lower area that will potentially cause a problem. Just because you have a bulge there, and we're going to go into this even more further, doesn't mean, oh, that's the exact source of my pain. But nonetheless, if there is a source of your pain in your lumbar spine, we can trace it down. If you pinch right here at L5, we can map it out, and you describe it. Pain radiates down the side, comes down the leg, comes on the front, and ends up between the first and fifth toe. And that's classic with a L5 nerve pinch. If it's on both sides, you get on both sides, one side, one side. If it's the whole cord that gets pinched, it's everything below that has symptoms. And it gives us an idea about how to work with this. So knowing the anatomy, knowing the symptoms gives us an idea about where we're going. Mechanical pain, inflammatory pain, lumbar back pain from another particular process. Knowing this map is all helpful in trying to figure out what's the best way to work you up and treat you. The straight leg raise also helps out. Most of our lumbar movement in our spine occurs at the L4, L5 disc. And when you bend your back, you can actually stretch those nerves. If they're already pinched and you stretch that nerve, you can get this nice radiating pain that courses beautifully down along that pathway I just showed you. And you can reproduce this by having a person lay down and raise their leg up at about 70 degrees. And if you get pain that radiates up into your foot, this is a strong suspicion that that's what's happening. Unfortunately, A lot of times people have pain in the back of their leg and they can't get their leg up that far because they have hamstrings that are tight, and it kind of throws things off a little bit. So you got to take everything into consideration and give you an idea about classic positive straight leg raise or something that makes you go, I can't exactly tell. It all comes down to the way the exam works and how limber you are and how tight your hamstrings are. So imaging studies. So why do we order imaging studies? And some people say, Doc, I got this back pain. I really want you to do an x-ray so we can figure out what's going on with my back. And there's a problem with that when you consider, well, it's kind of like saying there's something flying in the air and you shoot it and you tell your dog, go get me a duck. It doesn't work out like that. Sometimes you can x-ray people's back, and just because you see something there doesn't necessarily mean it's what's causing a problem. And we're going to talk about that further. But patients with major progressive neurologic symptoms or dysfunction, or you suspect an underlying systemic disease, this is people that we're going to image first. Because a lot of times we image people and we find something and it had nothing to do with their problem at all, and you end up chasing some particular process that may or may not be causing you an issue. So if you don't have anything that makes you think there's a systemic problem or a progressive neurologic dysfunction or something that's potentially, if we do nothing, could cause a problem, what we do is we don't image you. We basically watch and see. We manage with conservative measures. Pain that goes beyond 6 to 8 weeks in a neurologic fashion, we get more aggressive with. 90% of the time, symptoms improve spontaneously by 8 weeks, no matter what we do. Whether you do anything or nothing, a lot of times they get better. So this is why the rationale behind, do we image first or do we kind of watch and see? And balancing that comes a lot with how your symptoms progressed, what they're looking like, and how you feel overall. MRI or X-ray obtained early has not been shown to predict clinical outcomes or affect the overall recovery. So quickly doing imaging studies for the purpose of trying to figure out what's happening is a lot of times not the answer. You go with how you present, how your map looks, how your symptoms are, where things go, and it gives an idea about where to best approach your treatment course. And then always thinking, let's first do no harm to our patients. So degenerative changes of the spine. We talked about the discs and the joint between the two discs and the joint right here, the facet joint. Normally you don't see any bone overgrowth in a normal spine. Here you see some bone overgrowth that makes this a very bulky looking joint that could possibly encroach on our neural foramen right here. You see bone overgrowth right here and shrinking of this disc. This bone overgrowth potentially can cause a problem, also can encroach on the spine and the back. Something to think about as far as degenerative changes. So here's a spine x-ray which clearly shows bone overgrowth in the front. You might have a little bit in the back, and you have some along these vertebral processes back here describing some issues. Now, if you look at this x-ray and you go, oh, look at this. This person's going to come in my office and they're going to have pain all along this part of their back and definitely down here and possibly something radiating their leg. It doesn't work that way. This person may have no complaints at all and may tell you, I'm fine, leave me alone. The x-ray, so a normal spine is straight up and down. Any scoliosis is going to affect the way we bear weight. Degenerative changes are directly proportional to the amount of weight or bearing load on that joint. So on this inside curvature, you're going to have more changes, and I'll show you some x-rays that look like that. So here's an example of my x-rays that I'm talking about. You see some processes changes here, not so much in the back, maybe some down here, nothing in the spine up in these regions. The back looks lined, it looks very nice. On this side you see some bone overgrowth here, here, here. You can see it all up and down the spine. You see very narrow discs. Between these two you intuitively want to say this person hurts a lot more than this one. But it doesn't work like that. You can't really say that. This person may be begging you to do surgery on them, and this one says, I'm fine, leave me alone. Another way to look at this, you see that curvature where the weight load bearing is. You see a lot more changes in the bone, much more on this side. Again, you might have no symptoms in either one of these patients, or either one could have a problem. So 80% of the time, or 85% of the time, when we x-ray looking for a source, a precise source can't necessarily be identified unless you have classic symptoms that go along with it and everything matches up and it just cogwheels beautifully and says, yeah, this is what's going on. A lot of times you get symptoms over here and actually you got pain on this side. It doesn't make a lot of sense because our x-ray shows a problem here. So 85% of the time, just randomly doing studies doesn't give us as physicians an idea to say, oh, I know exactly what's going on with you, and it's frustrating for physicians and patients in the same. So I just say, just be careful to jump into that, toe-to-toe battle with your physician and saying, no, I've got this problem and it's got to be taken care of. Because say if you say, oh, well, your back pain's right here, let's go through and do surgery and let's just chop those little things off and do fine. A lot of times, actually, the studies would show that really doesn't show any benefit at all. Unless there's a pinched nerve that you can directly correlate to this area, you tend to leave this alone. Because if it's just pain relief you're looking for, surgery has not been shown to be beneficial. If it's a pinched nerve, relieving that pinch or stress on that nerve with a decompression surgery has been shown to be beneficial, but relieving pain, not so much. And that's the big issues that we got to pay attention with. Don't jump into something you can't take back. Imaging studies to rule out serious conditions are what we do. Common degenerative changes are expected to be present when you look at these imaging studies. And I'm going to show you a few more imaging studies to give you an idea about what we're talking about. Disc disease. So the disc, if you imagine a disc, it's kind of like a small little jelly donut. It sits there. You have this fibrous capsule on the outside, and the internal side is like this little gooey, little squishy material that acts like a little shock absorber. Well, if you cause a lot of pressure on this little shock absorber, you can actually bulge a disc, herniate a disc, or potentially rupture the disc. And this inside can actually come out. So patients say, I got a herniated disc and it's causing me some significant problems. This is an MRI which shows a normal disc here, a little slight bulge here with some degenerative process here, and also here. You see much more of a bulge and also degenerative changes in that disc. However, that person may have no symptoms at all. They may tell you, I'm completely fine. As a matter of fact, you can actually, just asymptomatic individuals, 27% of them, willy-nilly, you do an MRI, you're going to see these changes on them, and they're going to say, I'm fine, I have no problems. So unless these symptoms correlate directly with an overall, that little anatomical map I showed you, or some other features, you can't just jump and say, that's the source of your problem, that's what's causing the issue. It doesn't necessarily work that way, because if you go in and rip out that little disc, we're not completely sure that that's going to make things better. Unfortunately, that's how this lumbar back process works. Rare in young people, peaks between age 44 and 50 years of age, and after that, these discs actually, the instance of the lumbar disc disease declines. And I think this is because in our life, when we're invincible in 23 or 20, we can do all these things, and as we get to be 44, we still think we're 20, and we do things that hurt ourselves. And beyond that, we start to realize, okay, I'm not going to mess with that because I know I'm going to hurt myself. And this is kind of the way the whole process works. With our body, we learn and we get better not to hurt ourselves. 2/3 of herniations are partially or completely resolved in 6 months. So you actually MRI this guy again in 6 months, could be completely gone, not even present at all. So that 6 months earlier, had you said, please just take my disc out, it's killing me, I know the problem, it could be gone by itself in 6 months. So you're still left with, as a physician, let's do no harm with my patient and make you feel better in the long run. And that's kind of like a crapshoot of sorts. And I would say my overall impression with this is, unless you absolutely need to go to surgery, be very skeptical about it, because I've heard so many people come in my office and say, I wish I never would have had surgery. I also see a lot of people come in my office and say, I'm so glad I had surgery because it's the greatest thing in the world. So where to give recommendations comes a lot with how you're doing, how your symptoms are progressing, and your relationship with your doctor and what they think is the best way to go. Okay. Let's see. Okay, so if you have pain after 6 weeks that correlates with your dermatomal pattern, everything's significantly, and we can say, yeah, definitely, we think this is causing a problem, then we think about possibly decompression surgery. And a decompression surgery, if you can imagine, you go right here, and they make a little chip down, or they can actually take this whole little back process off by chopping here, and come in and pull out this little material, or possibly fuse this area. And anyway, it's called a decompression surgery, and it can potentially be helpful, but nonetheless, giving you 100% assurance that's going to be beneficial, I dare say you're not going to find many doctors that are going to give you 100% assurance in these situations, because a lot of times, if it's a pinched nerve, that gets better, but pain is hard to get better overall as an assurance. Spondylolysis. A lot of times people have this, I have this, and you don't even know you have it. It generally happens if you're at age 16. It's associated with repetitive trauma, strenuous sports, or potentially just the way you were born. It runs in families. This runs in my family. And it has to do with this little area right here in your lower spine. If that area is widened or extra thin, it can break. And this x-ray kind of shows the little picture. This one didn't come out so well, so I have this on the side. but it's an oblique view of the lumbar spine, and it's called a Scotty dog image because you can see his little eye and his ear and his nose and his little legs that come around. And if he's wearing a collar like this, it's broken. All right? And if you have that, is it terrible? Not really, because a lot of times it doesn't bother you at all. Does it progress? Can it cause an issue? Well, 15% of the time it can. But a lot of times it doesn't. So when you look at this little image here, you can see this is not aligned, and you can see the break right there. If you're grade 1 or grade 2, we leave this alone and we manage it conservatively. Core strengthening exercises, abdominal strengthening exercises. If you're here 3 or 4, this is when we say, okay, uncle, we're going to go ahead and fuse your back. What's the chances it's going to progress? 15%. How do we know? You can do serial x-rays, you can follow your symptoms, there's a bunch of ways to manage this or analyze this, but jumping into a situation where you can say everybody's in the same boat is very much being presumptive and wouldn't be a good idea. If you have, okay, and anything like a pinched spine or spinal stenosis or pinch on the spine, you proceed to a surgery. So this is spinal stenosis. So spinal stenosis is when the actual cord sits in that little canal right there. If there's something that comes along and pinches that cord, whether it's from the disc side or whether it's from the facet joint side right here, pinching the cord can cause stenosis. Not everybody's born the same. Sometimes that gap when you're born is wider than other people. So if you combine something like a narrow cord, a narrow spinal canal with something like this, you're going to get symptoms at an earlier age. And these symptoms tend to be associated with spinal stenosis. We're going to go into that, what those symptoms are. This is kind of like a cartoon image of what that looks like. So 20 to 30% of asymptomatic adults, random checked people, greater than 60, are going to have this happening in their spine, and they have no symptoms from it at all. All right? Congenital stenosis, we talked about it right here. You get symptoms at a younger age, especially as your body starts to turn into that 80-year-old person sitting in the wheelchair, and it slowly is going towards that little person. This is what happens to us all. And if it happens to this person, you're going to get symptoms at a younger age. Neurogenic claudication. So neurogenic claudication is the symptoms that, as a physician, the doctor term we use, that gives us an idea to think about spinal stenosis. So neurogenic claudication, pain in the buttocks, thighs, and legs. Sounds like regular back pain, yeah. But this one is induced by standing, and classically, this is the big thing, gets better by flexing forward. So your doctor always asks you, does your pain get better when you sit on a grocery cart or lean forward on it? Because that would give us an idea about something like this is happening. When you lean forward, it relieves that pain, or potentially by sitting. So osteoporotic fracture. Let me see if we can go back to here. If you have these kind of symptoms that are significant and progressing, what they would do is a decompression surgery, and that's when they chop this off and take this out. And the decision to do that comes out with you and your doctor. Other things you can do is potentially go in here and put an injection to relieve what we call inflammation. Whenever you have a nidus for inflammation or irritation, because quite honestly, you can wake up in the morning and your back is killing you. Did you injure yourself at night? Did you do something at night while you're sleeping to cause this? No, it just happens. So to call it inflammation is a little bit tough. But nonetheless, it sets up this chemical response where it irritates the ligaments, the muscles, the joints, and it causes this whirlwind of activity that causes pain. So a lot of times, epidural injections are what people recommend to calm things down, and that's something that is a possibility in spinal stenosis situations, which offers temporary relief. Osteoporotic fractures tend to be asymptomatic. About 70% of the time you get these fractures and you have no clue it ever happened. And some doctor goes, oh gosh, we just x-rayed your back and we found this little compression. And you say, I didn't know anything about it. Sometimes it's actually there and you know when you did it. I bent down, I lifted up, and pow, I felt it pop and crush, and it was horribly terrible. In that situation, when it's painful and it's in the acute situation, like less than 2-3 days, they can drill a hole right here, come into the side, and blow this up with a little balloon and cement it, and it's called kyphoplasty. And that can be beneficial for osteoporotic fractures. All right? The treatment of lumbar back pain. So, aggressive therapy for lumbar back pain, where we talk about aggressive therapy, injection, surgery, something that we're aggressively pushing you through to do something to manipulate your back to make it go away, is we lean that way if you have evidence of a significant neural compression, something with a lot of weakness or numbness or something in effect that's radiating down your back, your legs, and it's terribly painful. If you have a pinch of the cord that's affecting your urine function, your bowel function, causing you to have a lot of numbness and weakness of the leg, which is consistent with a cord compression, that's also an emergent situation where we're going to push you to surgery very quickly. If we think that you could have a potential underlying cancer, infection, possibly spondyloarthropathy or visceral disease like abdominal or aneurysm or some kind of intestinal problem that's caused you to have back pain, then we're going to proceed in also in a different manner or faster than watch and wait. Conservative therapy, we do pain management with analgesia, physical therapy for the most part. We divide, there's two concepts here: acute lumbar back pain less than 3 months, chronic lumbar back pain greater than 3 months. Anything in the acute setting, we tend to try and watch and see, because the 90% of the time it's going to get better on its own. If we're greater than 6 weeks, we call that the subacute time, and that gives us an idea about maybe we need to consider more aggressive approaches to management, and we involve multiple specialties in this particular treatment course. Unfortunately, chronic lumbar back pain is more difficult to manage. So acute and chronic lumbar back pain. The whole adage, if you don't use it, you lose it, applies here tremendously. We recommend stay active with limits permitted by your pain. So continue to do the things you normally do. We manage to control the symptoms. If you do nothing like bed rest, your muscles tend to atrophy. If you ever think about it this way, and I kind of use this as an analogy, it makes a lot of sense. When they send patients or astronauts up into space in the space shuttle, and they spend some time out there, when they land that space shuttle, those guys, they can't walk. They have to carry them off that space shuttle in stretchers because their muscles have atrophied to a point that the gravity is a significant factor on them. So bed rest can actually prolong recovery for that same concept. If you sit there and do nothing, those muscles kind of get couch potato type muscles, and it actually can make things worse. Stay active. Core strength and exercise is going to be the paramount in getting this better and keeping things under control. We recommend aspirin type medicine, Tylenol. You can use short courses of narcotics in these situations. Muscle relaxers should be beneficial. Moist heat are all fair game for treating acute lumbar back pain. Manipulative therapy, like going to a chiropractor, if it works, that's great. But the studies don't show that it's any better than conventional therapy for managing chronic or acute lumbar back pain in long-term situations. We consider injections greater than 6 weeks, but the effectiveness is mostly seen and can be predicted if you have nerves that are pinched. And a lot of times these tend to be temporary in measure, and they don't necessarily prevent you from long-term having to have surgery to begin with. So you kind of take the situation and you pay attention, you look how it's progressing and goes forward, and you move and treat in conjunction with your recommendations of your doctors that you're seeing, and that's the best therapy we have at this point for acute lumbar back pain. Chronic lumbar back pain is rather disheartening in a sense for patients and physicians alike, because it is chronic in nature. It can be debilitating, and it can be absolutely frustrating for everybody. We tend to manage flares as above. It tends to be a chronic process with these episodic flares that happen. Complete relief of pain, unfortunately, is unrealistic for many people in these situations. And what we can recommend is getting a situation where you can control your pain to a level that makes things tolerable. And again, you come back to do no harm. So as your physician sitting there talking to your patient, and you're saying, what can we possibly do that's going to make you get pain relief, but in the long run is not going to cause any problems? And every time you talk to people, they're going to give you stories, like I said before. Oh my gosh, I had back pain and I had surgery. I'm so glad I had it. At the same time, you can hear somebody say, I had back pain, I had surgery, I wish I never would have had it. So giving these recommendations to go forward with aggressive therapy is always very, you had to take it with a lot of trepidation and do it in conjunction with your doctors involved. We do know from studies that have done in the past, just following serial images, a lot of times things get better on their own, and predicting who that's going to be, it's hard to say. So in these situations, we recommend core strengthening, focusing on core strengthening, because it's very beneficial in the long run in helping people maintain their function. Is it going to get you complete relief? But no, the whole thing is, as we go through life and we slowly progress towards that 80-year-old person in a wheelchair, our body's going to depreciate. In doing so, you're going to have more pain and more stiffness. Keeping that core strengthening is going to help your back stay aligned and prevent you from having these episodic flares, hopefully is the situation.